Dr. Jonathan Tripp joining us in studio this morning from Tripp Family Medicine right here in Twin Falls, Idaho, called Better Health. We do this every Wednesday morning between 8:30 and 9 o'clock. Bill Colley handling the telephones this morning. If you have a question or comment for the doctor on News Radio 1310 KLIX and newsradio1310.com. First of all, welcome back. This is 3 straight weeks you've done this. I think this is the first time.
It's a record, huh?
Yeah.
Well, and next week we're going to bring, we have 2 new practitioners in our office, one that's been there for about a month and the other starts on Monday, and we're going to corral one or both of them to come with us. So we'll introduce you to the idea of what are the different levels of healthcare practitioners that we commonly see in the U.S. And most people are familiar with doctors, but physician assistants and nurse practitioners are often kind of misunderstood as to where they are and what their training really is.
And when Arnie Walker was here last week, he was already telling me about one of your new staffers and singing the praises. So,
well, good.
Yes.
Good. No, I think I have just really sharp people all the way from, the doctor on down to, who cleans the toilets, which sometimes is the doctor too. But we have a great office.
Family practice.
It is family practice. Yeah, that's right. If I had horses, I'd clean the stalls.
Yes, 8:35, and of course 49. Actually, I got to take a closer look at that temperature. The doctor is talking about cancer today. Not necessarily all bad news. Some of it is about prevention. I did read something the other day online because we've been looking for a cure for it for years. But I read where a doctor was commenting, saying that a cure might not necessarily be available because cells continue to mutate. So we're always going to maybe be dealing with it. It's just a matter of, can we treat it to the point where we can knock it out early when that happens?
Boy, that is the what do they call that? The $64 question.
Yeah.
And the answer is there's research that is new and exciting about different ways to treat cancer. We traditionally have used radiation and chemotherapy, and there's techniques along the lines of what's called immunotherapy, using your own antibodies to go and attack cancer cells. That is probably the most exciting to me. But there's other techniques that are being developed in a vaccine type manner, which is similar to the immunotherapy. But melanoma is a big killer and very severe if it gets very far. That's one that I have a father-in-law who died of that with no known primary lesion on the skin. But the bottom line is they had just come out with some of this immunotype therapy to try to go and attack the cells using what are called natural killer cells that your body produces. But he was not eligible for that therapy at the time. He might have been today. And so those continue to develop and increase what was really a risk of death, or a probability of death of being 80% within a year, or actually within about 6 months, to a lot of the people had a prolonged lifespan of up to about 4 years, which sounds not like too much, but there was a small group in that study, about 10% of them, that went on to have essentially a cure, which is where the real hope is. So there are things being developed in each different type of cancer because one size does not fit all. But it is true that, kind of like with the flu, that mutates. And so we do our best to put in a flu vaccine, the most common flu viruses from last year, in hopes that they will be the predominant ones this year, or be a mutation of it, so that when you get your flu vaccine, you have some immunity, if not full immunity, to the virus. So I could see that happening with cancer as well. Once you, quote, cure one version, it'll do a little mutation, and you have to alter your therapy.
You have a couple of points today, too. I know in your notes that there are some common strains and that there are some deadly strains. In other words, it comes down to what you have and also, I guess, sometimes what part of the body it's in.
Yeah, what's interesting is we hear a lot, and this month is Breast Cancer Awareness Month. And so it's, wear your pink, and that's all exciting. And I hear lots of slogans that I would say that the marketers have taken the gloves off. They talk about all kinds of things to save boobies, and have shirts that say the same thing. And I think that's fun. That's a lot of fun. We appreciate that. So people are probably most aware of breast cancer, and that's a lot of marketing. and has been very beneficial. And when you look at the most common cancers, not the most deadly, but the most common, breast cancer just barely ekes out lung cancer. And that's probably a shift over the last 20 years because lung cancer due to smoking was number one and it's barely number two. And we have about 230 new cases of breast cancer, 230,000 new cases of breast cancer a year, and 221,000 cases of lung cancer a year. But what's interesting is that the death rate, if you take the lung cancer, the estimated death is 158,000, and the deaths from breast cancer is only 40. So it's a big difference, but at the same time, when we quit smoking, that one's pretty close to going away. Breast cancer, on the other hand, requires constant monitoring, and the preventative measures to how to check for breast cancer have changed over the last several years. We've gone from where they would say a woman must do a self breast exam every month to dropping it to about 4 times a year. And the recommendations on mammograms are a little more lax, but I'd strongly encourage anybody over 50 to do a mammogram every year.
We've got more with Dr. Jonathan Tripp on the way. And do want to point out we're talking about cancer today, but we're also going to be talking not just about risks and deaths, but also about how you can, work to prevent it as well, because we want to make sure people are in good health and have a long life. It's 49. It's coming up on 20 minutes away from 9 o'clock. You're listening to Better Health on Top Story this morning with Bill Colley as well on News Radio 1310 KLIX and newsradio1310.com. In the studio with us, Dr. Jonathan Tripp. This morning we're talking cancer on Better Health with Tripp Family Medicine. It's 8:44, coming up on 8:44, 50. And if you have a comment or question, you may know someone obviously who perhaps even had a recent diagnosis, or you may be dealing with this on your own, or you may be a success story. We'd welcome your telephone calls. The number 736-0300, 736-0300. And we're talking a little bit, I know this morning too, about what risk factors are. And one thing, you mentioned heavy metals, for instance, and I guess I've heard something about that now and then. A friend of mine who survived brain cancer once said to me that we have such chemical pollution in the world now that she thinks that has increased certain rates. But she's a layperson talking about that, obviously.
Right. There's a lot of fears that go into a lot of contaminants, but heavy metals are known to be harmful to the body and to the brain. Uh, they basically get in the way of the proper function of a cell. And so I had a niece who had lead exposure at an early age because of the house they were living in, and that became a big concern that required her to get what's called chelation therapy, which is using an IV and some other metals, elements, to try to reabsorb the lead out of her body. And because it stays in the cells, it's a slow process. But if it's allowed to remain, you have a decreased mental function. So you have essentially retardation because of heavy metal exposure. And we know, I guess if you go back to my grandparents' time, mercury, the stuff that used to be in most of the thermometers, they'd play with it in science class at school, and watch it roll around in their hand, not knowing that this was being absorbed into their skin, and actually causing health problems that way. So we have mercury, we have cyanide, we have lead. Those are probably the most common. Arsenic is poison that is common in soils across the U.S. and is one of the things we test for when we check water for water wells. So these are all things that are present. The question is, are they concentrated because of our industrial nation's, use of uh, manufacturing and how things are either dumped or taken care of? And so, and then if we go the step further, you go to nuclear waste, and that's one that we know has a direct effect on changing cells rapidly and causing all kinds of cancers. So, yeah, the heavy metals are a big deal. You do your best to filter water is probably the main source to watch out for because the water gets contaminated by spills on the surface. Interesting, I just heard a story on fracking, the way that they're trying to extract oil from shale areas, especially Pennsylvania is heavy in this. And they were finding complaints of contamination of the water in the area where fracking was going on. And it was interesting to hear the report because the government's report on it was, boy, we're glad we're finding out that this is contamination based on spills on the surface because we can find those. We can help fix those. But what they're saying is, oh, don't worry about what's going on underneath the ground, which to me says, I think that's a little nearsightedness on that. At least I hate to use the word spin, but it sounds like that's what it was, is a limited exposure to the public of what might really be going on with fracking because it's big business. It's big money and helps keep our oil prices down. Um, and that's a contributor. So, and I'm not against business. I come from a very entrepreneurial family, and so I don't want to portray that image. But
Haven't known one yourself, come to think of it.
yeah, by the way, that's true. I am kind of on my own. The but kind of getting back to the other issues, what are some of the risk factors? Well, different populations have different risk factors. For example, somebody who's Native American has a 50% chance of developing diabetes in their lifetime. So there's different populations have different rates of certain cancers. So that's a risk factor you can't change. But
Well, I saw something on this last week. A study, and I don't know if it's been replicated yet, out of Scandinavia, hints that perhaps people who are really tall have a higher factor of cancer than people who are of average height or shorter.
that'll work for me. Especially if you can't see me on the radio, but I'm not of the taller variety.
we,
In
we,
fact, one of my first practice is funny. I had a lady come in, and it was probably about 3 months into my first practice, and she'd seen a picture in the newspaper and come in, and her first response was, "You don't look as tall as your picture." So yeah, I'll take that one for mine. But yeah, we have things that we can't change about our genetics, and there's predispositions, what's called a BRCA or BRCA gene mutation that predisposes some women much more to breast cancer risks than others. What's interesting is I recently learned the cost of doing that test and was and told me why when we have somebody that's concerned about that, why they have them do genetic counseling and investigation on the family before they even run the blood test. Because the blood test alone is about $20,000.
Wow.
So a little bit of counseling costs a lot less.
When we talk about these factors and all, there's also sometimes efforts. A friend of mine once put it this way to me. He said it's like a revolver. You're playing Russian roulette, and if you start smoking and you drink heavily and you do all of these other things, you're actually putting extra bullets into that chamber. And that's how his analogy was to it. But there are certain things you can do, even if you have a genetic predisposition, that can at least
To avoid,
right.
yeah. If you have a predisposition, you really want to avoid anything that would incite cell changes. And cells change based on irritation. So whether it's skin and sun UV rays, whether it's lung cancer, the lung cells change because of the chronic irritation from smoking, as well as the chemicals that are involved. You want to avoid those things. And I'll give you a statistic that's you know, hard to believe, but when you talk about cancers of the head and neck, uh, 5%, so 95% are associated with people that drink and smoke. The other 5% are not. So if you want to reduce your risk of a head and neck type cancer, throat cancer, salivary gland, anything like that, don't don't drink and smoke. I know it sounds too easy, but there's a 95% reduction, boom, right there. And we talk about cancer because it's threatening and it's scary because it kind of comes out of nowhere. But number one killer in our country is still cardiovascular disease, so heart disease. But close behind that, if you group all the cancers, is the different cancers. And number one, let me give you some of the deadliest ones, and then we'll talk about some of what else to do. The deadliest ones: lung and bronchial cancer. Number two, colon cancer, or what some people talk about rectal cancer. That's just a different part of the colon. And number three is a big drop down, and that's breast cancer. Pancreatic cancer doesn't have as many uh, people diagnosed with it, but it is among the deadlier cancers. Prostate cancer is common, but only about 15% of people with prostate cancer actually die of prostate cancer. Leukemia, non-Hodgkin's lymphoma, liver cancer, ovarian cancer is way down at number 9, and esophageal cancer, number 10. These are still the top 10. Esophageal cancer is one that's scary because there's no good test for it. And by the time you've found it, It's, in the middle of your chest. It's where lots of lymph nodes are, and frequently it's already elsewhere before you even know it's there. And you can't cut out the esophagus and eat very well.
We have a caller with us. You're up next, and you're on the air with Dr. Jonathan Tripp on Better Health.
Hi, great program. I really appreciate Dr. Tripp's weekly visit.
Thank you.
Couple of comments, looking for some feedback. National Institute of Health has a breast cancer assessment tool on the website. I guess one, I'm wondering how accurate that is. And then two, I'm under the impression that there's some programs for low-income women for breast cancer screening. I was wondering if you can comment on that, and I'll just get off the line and let you comment.
Absolutely. In fact, we have a push right now by our what I'll call our free clinic called the Wellness Tree has been doing a push this month for every woman to get their mammogram done, and there's an ability to utilize some programs for, should we say, low socioeconomic status women so that they can get a mammogram either free of charge or very dramatically reduced cost. And you can usually find that out through the hospital that has the mammogram machine. You can also contact your physician and see if they can help you. But I think if you look online, I'm trying to remember the name of the group. I got a postcard this week encouraging you to go either to where we are here, St. Luke's, or over in Cassia County. I want to say Minidoka also they were all on this postcard, and they talked about a women's program that will help you pay for this if you can't afford it, but recommending this is the best thing you can do for the health of your family is to keep you healthy.
I
So,
wonder if you could even go to Google and just write in, women's, and something related to that, and come up with a
yeah,
a couple of
how do I
sites.
pay for my mammogram?
Right.
I bet you could do that on online. Regarding the breast cancer assessment tool, I have not gone through it in detail, and they do talk about this gene mutation that I spoke about, the BRCA1 or 2. If you know that about the family, that's a big change. But what they're trying to do at the end of all this is saying, what's my calculated risk, and do I need to do, how frequently should I get um, mammograms? Is I think the bottom line of it all, and the controversy with that is you have about three different groups. U.S. Health Task Force is one. Uh, National Institutes for Health, the American Cancer Society, trying to remember what it's called, the American Radiology Society. So you have different groups that are saying start at age 40, start at age 50, do something in between as to when to get mammograms yearly. But if there's a strong family history of breast cancer, I would absolutely recommend at least by age 40 do one mammogram. And often, if there's no risk, I really would say, do one at 40, one at 45, one at 50, and then every year thereafter to avoid um, kind of more serious threats to breast cancer because it is most common uh, to diagnose, but we're looking for it better. And I like that. And I'd rather find it early. My mom had breast cancer.
We have another caller with us. We've got a couple of minutes before we wrap up Better Health today, and you're up next on News Radio 1310 KLIX. What's on your mind?
Okay, I'm not trying to take over the show. I looked it up. Does Women's Health Check sound right?
Women's health check?
Yes.
Yes. Yeah, that's exactly
Okay.
what I found on that
We've
postcard.
got a new producer
Cool.
for the show. I
There you
thank you.
go.
Sorry
Yeah,
about that.
Women's Health Check is the name of the organization that helps provide free or low cost mammograms. So I appreciate you bringing that up. I didn't have that name off the top of my head.
You referenced esophageal, and I had a coworker, Bianca Solorzano. She ended up going to work at CBS News for a long time, but we worked together at a TV station years and years ago. And her father was a surgeon in the Wilkes-Barre area of Pennsylvania.
Sure.
He died after being diagnosed with that. Yet I had a neighbor who had it, and a year later I saw him at the library one day checking out some books. So some people have survived, but it does seem that it's one of those higher mortality issues.
Yeah, ovarian cancer is another one that's scary, and there is no good screening, or shall I say, cost effective screening exam. There's an excellent screening exam, and that is an ultrasound to look at the ovaries. But the problem is when do you do that ultrasound? Because You can't do an ultrasound at age 30 and say I'm good. And yet, an ultrasound is $300 to $500, and to do that every year just for the sake of saying someday I might have ovarian cancer doesn't, the dollars don't make sense. And so when we get those recommendations for what screenings to do, they really are looking at it statistically and saying how many screenings and how many procedures do we have to do before we save one life. And if that, is 10,000 or 100,000 screenings and procedures, then the recommendations usually come back and say, that's not a very cost-effective procedure or screening. Now, on the other hand, if somebody said, my grandma, my mom, and all my aunts had ovarian cancer, well, I tell you what, I would be doing an ultrasound now and then. But there's no good recommendation to say when.
It's that family history that, though, does have some determination in this.
Big change. It's all, as they say, it's all in the genes.
I had one family member who had a colorectal cancer, and but we don't have much cancer in the family. And I just mentioned that to my primary care physician one day, and he sent me off for my first inspection.
Yep.
And then when my brother came down with it, I had to go back again. And so obviously, the people are trying to keep an eye on that to manage it beforehand.
Yeah, I have a family history of several cancers, but I'm glad you mentioned that you don't have much history of cancer in the family. I want to address that one cancer, because they've had different kinds of cancer, doesn't mean you're at high risk for any of those cancers. So a lot of people say, well, my parents had basal cell carcinoma on the face, and I have another relative that had colon cancer. Well, that doesn't mean you're at increased risk for breast cancer. So does that help?
It does. It does. I want to thank Dr. Jonathan Tripp for coming by today. Better Health with Tripp Family Medicine. Speaking of cancer, we have a guest coming up, a guest, we should say, in just a few minutes. Breast Cancer Awareness Month, October. And we've got more details on that in just a few minutes right here on News Radio 1310 KLIX and newsradio1310.com.